어떻게 없앨 수 있지 않니, 저거? 그거 없앨 수 있는데.
팅페이 컨트롤 숨기기 보고 있었어.
Good morning to everyone. I am Dr. Joa, known as Southern Hospital, and today I'm going to present my EGM conference. Thanks for joining my EGM conference. Let me introduce my brief history. This is the 65-year-old lady, and she complained is palpitation, and also had past medical history of hypothyroidism and post-menopause syndrome. And echocardiography show normal size cardiac chamber with normal ejection fraction 17%, and realization abnormality of LV filling pattern. E prime is about 9. Echo was taken at March 2025. This is the wearable patch ECG. It was taken at April 2025 and show SPT episodes. And also this is the trail lead ECG. It was taken at May 2025.
Can you explain what did you see in the wearable ECG monitor?
Wearable ECG monitor. I think this is QRS tachycardia, and I think this is PP wave, and so I think it is short RP tachycardia. P wave after the QRS. Yeah. And so I think it is neurocomplex tachycardia, short RP tachycardia.
When you interpret the rhythm strip ECG,
yes,
you should carefully observe at the beginning of tachycardia and termination of tachycardia. You can find important clues at the time. So did you see anything at the beginning of tachy and the termination of tachy? Jaya, do you see anything?
Sure.
Anyway, at the termination point, ST segment is a little shaggy. In other words, it terminates by P wave, right? Narrow QRS and P wave. Here. Okay. And, how about the beginning of tachycardia? Narrow QRS starts here, but do you see any P wave before? And if you comparing the QRS morphology of this one and this guys, it must be the retrograde P wave, right? But there, P wave looks like here. First bit, narrow QRS, premature narrow QRS, and P wave looks here. And this guy and this guy shows different QRS morphology, right? Okay. But if there is no further comments, let's go ahead.
This is a trail ECG. It was taken at May 2025, and it's normal sinus rhythm, and I cannot see the pre-excitation. And this is the chest X-ray of this patient. It was taken at March 2025. It's a little bit increased cardiothoracic ratio. Electrophysiology study was done at July 2025. This is the initial catheter position, RU35 and LU35. We use polar catheter in RE and PS, and also parabola catheter in RE, in RV and HIS. This is the initial rhythm of the EPS study, normal sinus rhythm. Sinus cycle length is about 1029 milliseconds, and AH interval is 67, and HB interval is 56, and QRS duration is about 76 milliseconds. And also we did RVV, RV-PASI, and at about 600 milliseconds, earliest before break atrial activity at H34 AVR. This is a VA block cycle length, RVV pacing 400 milliseconds. And also VRP occurred at SPEST 600 to 60 milliseconds. And also we can see no VA decremented property by SPEST 600 420 to 600 400 410 milliseconds. This is the AV block cycle length. It occurs in RAP 360 milliseconds. And also we did Parahesian pacing, and it showed a pathway pattern. The interval is 86 milliseconds, fifth VA interval.
What is pathway pattern?
Pathway pattern, it can indicate VA interval is fixed, not changing.
VA interval, you measured from where to where?
QRS
sunset to where?
I measure beginning of the QRS to the earliest A.
And VA interval same regardless of QRS width. Am I right?
Yes, this QRS, narrow QRS, and is about VA interval is 86 milliseconds, and this is wide QRS, and VA interval is also 86 milliseconds, almost same. And so I think it is pathway pattern.
Why the beginning of line is a little later than the pacing leap? And this interval same? I don't know who measured it, but it looks the same, but I'm talking about the initiation point of your measurement. Okay, let's go ahead.
And also tachycardia induced by SAEST 600 320 milliseconds. This is a tachycardia cycle length is about 511 milliseconds, and AH interval is 341 milliseconds. HB is 41 milliseconds, and VA interval is 105 milliseconds, and QRS duration is 91 milliseconds.
Cycle length 511. Okay, can you explain the tachycardia mechanism bit by bit? I don't know why the older line shows double line. It is my eye problem. Did you draw one more line?
Yes. One more line and so.
But why is it
Yes.
not focused? Why is it different to the original line? Okay, please explain the bit by bit. I think AA interval is changing, right? Alternating.
Yes, alternating.
Because you draw the too many lines is confusing, but generally AA interval looks like the long short pattern.
Short.
Okay, and please do not make many lines. Yeah, it is very difficult to observe and make a bias to the audience. Okay, please explain why there is a long short pattern.
I think we can see varying tachycardia cycle length in this EGM. And it could be, it can be seen in ABRT. And I am not sure the exact mechanism.
Diagnosis is not that important. You can make diagnosis as the last point, but you should explain the phenomenon you observe. Junior, can you explain?
Looks like AHC intervals keep changing. Need to be. I think maybe patient have a during difficulty in one time. And
좀 자신 있게 크게 좀 얘기해봐. 응? 뭐라 그랬는데? 하나도 못 알아.
I think the AHC time is changing.
AH interval changing. That's why it is the bigeminal pattern.
So maybe this patient have a dual avenue difficulty and goes to the best in one time was best day.
Because of the AH interval changing. But why is the bigeminal pattern changing? And how do you prove it? 조승원 선생님 한 수 가르쳐 주실래요?
한국말
네? They can understand. Am I right?
내가 생각하기에는 retrograde ablation 안구가 하나
Yeah,
인정.
you follow the mouse where the Dr. Joe point out. 밑에 거. 옆에 있는 건 올려야 될 거야. 전화기 큰거 같아.
여기 스폰서랑 그의 스폰서가 좀 다른 것 같은데 거기에 따라서 사이클렉스가 달라지고 요거는 이제 제 생각에는 이 선생님이 얘기하는 것처럼 이걸 이거 테올로기에서 네트워크를 수로 세탈 악세사리 패스를 타고 네트워크를 컨덕션 현상을 보여준다.
septal accessory pathway고 하나는
네,
slow pathway to
네.
So combine the AB node reentry and ABRT. That is your explanation. Okay. So yeah, Dr. Joe pointed a very important point. We need to include in the differential diagnosis of two tachycardia coming together. So yeah, Dr. Joe explained it very clearly. Not only activate sequence. If you look at the CS34, follow the mouse, polarity changing, right? It's quite big. Okay. There, interval is bigeminal pattern. In this case, you need to take which one leads this bigeminal pattern. So if there's his leads this guy, probably there's some AB node area is the main part of the reentrance circuit. But one thing we need to recognize, the VA interval, VA linking is maintained, right? So retroid activation is going through the accessory pathway because the VA, there's a VA linking and the VA interval is same, but the conduction pattern is little different and the cycle length is different. So we need to include the combined AB node reentry and accessory pathway and two different accessory pathway among your differential diagnosis. Another one is that if AB node is the long time ago we call it the intermediate at the slow pathway. If the slow pathway conduction is multiple pattern, and because of restitution is fast, slow, the alternating, it could be longer pattern AB node. Okay, so we need to differentiate diagnose at least 3 different tachycardia based on this issue. Any other comment? I missed some of the differential diagnosis. So I always see the opposite side. Professor,
Yeah, you're with you.
okay, let's go ahead.
So this patient show a positive V reset. And also this is actually ECG, neurocurious tachycardia.
QRS alternance. And apparent retroid P wave in V1. Yeah. Okay.
And also we did the LV pacing and also show the earliest atrial activity at H34.
H34. What is H34?
Earliest retrograde atrial activity is 8.
Oh, okay, okay.
H34.
Yeah. I confused to RB. That is the earliest point, right?
Yes. This is the earliest point.
Okay.
And this is summary of this case. And we can see the earliest retrograde atrial activity at H34 during RBPZ. And also during SPEST, we cannot see the decremental property and parahesium pacing indicate that wave pattern. And we did LVPZ and earliest atrial activity at H34. And neurocurious tachycardia induced by SAEST, the central at 320 milliseconds. At that time, the interval more than 60 milliseconds, and we reset by his respiratory pace. And so this case is conceived bypass tract left postural septal inducible autonomic AVRT using AV node for ambiguous conduction and accessory pathway for retrograde conduction.
So how will you confirm it, Dr. Joe?
I will confirm this is the left post receptor accessory pathway by
We know, everybody know. But the question is this just a bystander with the AV node reentry or double bypass track or AV node reentry plus AVRT? How do you differentiate it? It's a very interesting case. 조승우 쌤, 어떻게 감별하면 될까요? 지져보는 거 말고. Everybody agreed that we can differentiate by burning the accessory pathway, right? But our brain training, how can we differentiate it?
There, AH jump.
No H jump. But we don't know because this patient has accessory pathway. It is so-called the electrotonic conduction, accessory pathway conduction hide the normal AV node conduction because the conduction resistance increases. I may try to give a strong current at CS34. We see that kind of a maneuver to exclude the accessory pathway related ABRT, right? So if you give a premature beat with high current at the CS34, that can make a refractory period A and B at the accessory pathway point. If it is really accessory pathway related ABRT, tachycardia should be terminated. But the ABRT with accessory pathway bystander, it may be the tachycardia may continue, right? Okay. Any other idea? Not by burning. 엄재현 선생님, differential diagnosis 강의 많이 하셨는데 좋은 방법 없어요?
하신 것 같아요. 이 정도면.
Okay, so how did you treat this patient?
This is the ablation catheter position, RAO view. This is LAO view. This is the EGM signal before RF ablation. This is the during RF ablation. And also can absent within 2 seconds. This is the same as before, 100 milliseconds, can absent within 2 seconds.
No. Before ablation signal, you showed it already. Okay, yeah, and then during ablation,
Yes,
bypass block, then okay,
this is the same as before.
Mm.
And also after
So you
ablation,
guys should display those 3 slides when you try to show the RF event.
and also this is after ablation, we did a single SB ESD and VA decremental property presence. And also this is VA conduction after RF between 800 milliseconds and iso-free infusion. This is the final EGM after radio frequency ablation. This is a 12 ECG.
Did you try the all basic EP study after ablation, including the AH jump
Yes,
and the no AH jump?
no agent. No agent.
Okay, so left side posterior septal or posterior accessory pathway generally has many atrial branch. Some people, the V insertion is from the MCV area and going through the posterior septal, posterior, the mitral annulus, and many the insertion. Even some patient has connected to ligament marshal. Those accessory pathway shows the decremental property, even though the accessory pathway. We discussed it during the procedure, right? So if there's the atrial insertion, multiple atrial insertion, you can see this kind of different activation pattern, but the long short long pattern of ABRT is unusual pattern of tachycardia. So before burning, you have to think about the all potential differential diagnosis and exclude it one by one, not by burn. Okay? Comments?
네. 보고 있을 것 같아요.
응?
저도 일단 지어보고 다시 인덕션 시켜봤어요.
That is so-called burn mapping. Dr. Huang hates it.
정진하겠습니다.
Okay. So, other comments? So, okay, thank you very much. I enjoyed the case very much. Okay. 자, 주말들 잘 보내십시오. 빵이 맨날